ते कुठल्या डॉक्टरांना दाखवलंय? पडोळे साहेबांना. बर. अटॅक आला होता का तेव्हा? बर. नेमकं कायसाठी गेलता मग डॉक्टरकडे त्यावेळेला? बर. हृदयाचे ठोके वाढले होते म्हणून गेला होता. चक्कर वगैरे आली होती का त्यावेळेला? बर. आता चालताना बर. पायाला सूज येते का आता? बर. आता अशा डॉक्टरला दाखवून किती दिवस झाले मग? बर. छातीची सोनोग्राफी कधी केली होती? 2-3 वर्षापूर्वीचा आहे का मग इको रिपोर्ट? राणी शोध आणि मला सांग. तसं नाही, सरळच ठेव. हा, डायलेटेड कार्डिओमायोपॅथी विथ, हा इकडे ये, आता उजवीकडे ये, विथ नॉर्मल, थांब तिथंच, कोरोनरी विथ सिव्हिअर लेफ्ट वेंट्रिकुलर. ओके, ठीक आहे. एजी डायलेटेड कार्डिओमायोपॅथी, नॉर्मल कोरोनरी लॅनोक्सिन. ओके, ठीक आहे. परळे सरांनी पाहिलेलं आहे. ठीक आहे, ओके, फाईन. नाही, कमीत कमी 3 महिन्यातून एकदा दाखवायचं तर ठेवा. बरोबर. चालतंय. आहेत ते मग ते आलं ध्यानात ऍक्च्युली सगळं बघूनच. थोडस काळजी घेत चला, काही होत नाही ऍक्च्युली. अजून 10-15 वर्ष तर काही प्रॉब्लेम येत नाही जर काळजी घेत केलं तर. बरं. जेवणात मीठ कमी ठेवा. अचानक टेन्शन घेणं, अचानक काही वजन उचलणं, अचानक पायऱ्या चढून जाणं, असं काही. बरोबर. चालतंय. आहे तिथं औषध, आमच्या साईडनं काही बदल नाही. चालतंय. आता कसं आहे, पहिली वेळ आहे. बरोबर. चालतंय. राणी आहेत तेच त्यांचं मेडिसिन कंटिन्यू. ओके. हायपरटेन्शन डायबिटीजचं आहे तेच कंटिन्यू. बाकीच्या त्यांच्या गोष्टी जशा आहेत तशा कंटिन्यू. मी देतो, प्रिस्क्रिप्शन लिहून देतो. So if you look at this particular patient, 63-year-old female, and she has dilated cardiomyopathy. She is already on a couple of medicines, like if you see over here, she is on DCMP. Probably she is having arrhythmia. That's why her physician has started her on diltiazem. Then she is on carvedilol and metoprolol. This is something two beta blockers are combined. Different beta blockers are combined. That is not somewhere indicated or that recommended as such. Basically, then you have so she is on pregabalin tablet. Probably for diabetes reason she was put on pregabalin. Then she is on torsemide, and lastly she is on teneligliptin for diabetes purposes, and then aspirin plus atorvastatin. So if we see the management of this patient is going really well, but what is worrisome is her ECG. If we find this is current ECG and heart rate is quite very high, heart rate is around 150. So what happens basically to this patient is that the more the heart rate, the patient is more uncomfortable there, and they are at more risk of developing pulmonary edema as well. So how this patient actually be treated is to reduce down her heart rate further, and she needs quite a very regular follow-up with the cardiologist and good monitoring. She may have electrolyte disturbances as well, because she is on torsemide as well. So we need to find out whether she is getting aldactone or not, because yes, she is already getting spironolactone, so that there should not be any issue. When we had a discussion with the patient, symptomatically she is better. There is no pedal edema, there is no dyspnea, there are no palpitations, there has not been any episode of syncope or giddiness. So what happens basically with such patient is We need to control their heart rates. We need to give them the diuretics very well, and need to take care that electrolyte disturbances doesn't happen. So this patient, actually what we are going to do, we are not going to change anything else for this particular patient, because she is on the right medications, apart from the observation that she is on metoprolol and she is on carvedilol both. So probably that needs to be get attended something in a way. She is hypertension, she is diabetic, and she probably might have had this ischemic heart disease. So old and STM, I will write that down. And LV dysfunction, severe LV dysfunction, ejection fraction is 20%. She is in NYHA 3 class, and she is having DCMP as the diagnosis. So dilated cardiomyopathy as the diagnosis. So these all diagnoses she is suffering from, and for that reason she needs to be continued with a lot of other medicines, not a lot of other medicines as well. Control her sugar, control her blood pressure. Her blood pressure target should be actually less than 130/80, because the more the blood pressure, the more the LVEDP, and more the LVEDP, the more the pulmonary congestion, and more pulmonary congestion may lead to have pulmonary edema for the patient in future. So so this way the patient should be continued with their management, continue with the diuretics, continue with the beta blockers, continue with the spironolactone, so that potassium get retains and electrolyte disturbances doesn't happen. Make sure that blood pressure remains constant and good, so that the renal system doesn't get affected, and her blood sugar levels also do control in very well manner the what way we want. So this is how this patient should be managed. And as a telemedicine, what should be our role, that this patient needs to have monitoring of blood pressure and blood sugar at least once in a month, and then also of heart rate, and monitoring of her symptoms, particularly palpitations and syncope, if they have and if they suffer from. So this way I think the telemedicine will help her on the ground, and such patients who are having chronic diseases, and it's a bit difficult for them to go far distant way to visit a cardiologist. Thank you.